Yo, mado wezon na I'm a shaman. Va miapa wana tohea ji utroya. Abaleka minya na ADANA yenya Anloga Development Association of North America. Duiba egba miawo wana tohea de. Midway ba every quarter mia astronado ke mia atna koko I help mia dokyo abna egbato yo nyaba dolele gado le yama kamia dakpana akamechio ba odi ba egba mia fonu viada cho ejidong na mia kokoje afagomi ita enye jijogada na ba otashi jinyeba mavanoja ma utroya aloza ma na miakowana ya avanami daka maganyi bana togbio bakle mama ba yo nyeba wana ya yo nya dolala fa ejedogemia la utroya di yemi pe amagado no abakpede mian utroya ne mia awawana na wana na chofodi ka madde kuku gade na mi ba abale ka afoma wole glone na mado ye fugbe viade na mi akoko wona na amashama na ase egomani ka agbabo wona leke bi wogenye ba mi afoga ka mi pe no abafo no na mi na mi mo na ge no wafo no na mi vo amashama na jagbagba wa mute yeba phone so hello yeba Michael nemia name on wa phone na mi na phone na mi body marako mi take notes amna na phone wa vo kwa kana bia ka la mashama shikwa ka marako mi atwa bia mi mona ga na mashama na bia la shikwa na pialo akpena mi ba mi de mona ba mado eyevu bia da na makoko ado wezona miapa amaganka minya shiba no wava afononami utroya akpenami. Ladies and gentlemen, I'd like to welcome you to the premier event of the Anloga Development Association of North America. It is a desire of this association that on a quarterly basis we will invite a guest speaker to come and address us and teach us or share with us some insight to a specific subject of choice for that particular occasion. And today it's a medium, is a first of its kind, and it is our distinguished pleasure and honor. I would like to say I am most honored to be asked to MC tonight's event. My name is Steve Day, for Steve, as most of you may know me. And today our guest is no other person but a man who is an authority on the subject that we are about to discuss. He is a Voltarian and he is an Angla. And he grew up somewhere in the Accra area, around the Banana Inn area, and before he sojourned here to the US. He has vast experience. He's a medical doctor. He's a clinical assistant professor of medicine at the University of Illinois, Illinois College of Medicine in Peoria, Illinois, which is just right in my backyard. He's also a cardiologist. He's OSF Healthcare Cardiovascular Institute in Peoria. He's a board certificate. Some of his board certifications are American Board of Internal Medicine, American Board of Internal Medicine, Cardiovascular Diseases, National Board of Cardiography Certification, and Board of Nuclear Cardiology. Ladies and gentlemen, please, it is my distinguished honor and pleasure to welcome to the platform. Please, let's all welcome Dr. Selassie Samuel Mototi. Please, let's welcome him to take the floor and deliver the address for the evening. Thank you. I yield to Dr. Selassie. Lucky, you are welcome. The floor is all yours, sir.
Akwa Steve, for your generous introduction. My brother, I did your number me young but me cho.
My partner increase of volume of here.
I did your number near young but me cho a jidonchi. So it's a pleasure for me to be here to talk to you about cardiovascular disease, which is what I do for a living. And today could not be a more appropriate day because this month of February is the American Heart Disease Awareness Month. And, you know, we're going around talking to people about, you know, prevention of cardiovascular disease. In fact, this morning I was interviewed on local radio about the same topics I'll be talking to you about today. And tomorrow I'll be on TV also talking about these same things. So these are important messages we want to convey to people because even though we're trained to treat disease, we are happy to prevent disease. So you don't have to come and see us. So I'm very happy to be here. Mr. Day, anytime you're ready for me to start, let me know, and I'll be happy to begin.
Hey, Actor Morocco, the floor is all yours, sir. Take it away.
Okay, so if we may begin, I will, let me see if I can share my screen with you. And by the way, can you hear me quite well?
Yeah.
Okay, very good. And can you see my screen?
Yes, we can, yes.
Beautiful, beautiful. All right, so. All right. Disappear. All right. So the subject of today's talk is prevention of cardiovascular disease. Again, I'm Selassie Mototi. I'm a cardiologist and a clinical assistant professor with University of Illinois College of Medicine at Peoria. So today we'll be talking about a variety of heart diseases. We'll talk about coronary artery disease, which is a disease involving the blood vessels that supply blood to the heart muscles. We'll talk about heart failure. We'll talk about, we'll touch a little bit on heart valve disease. So the heart has valves which direct blood to flow from one chamber to another and close to prevent backflow of blood. And there can be disease involving these valves, which affects their function in terms of whether they open well or close well. So we're going to talk about that very briefly. We'll talk about heart rhythm abnormalities. So, you know, these are, when we talk about heart rhythms, we're talking about the regularity or irregularity with which your heart beats, whether it beats so fast, slow, stuff like that. We'll talk about the common conditions that we need to know about. And then we'll also talk about vascular disease. So when we say cardiovascular, we're talking about the heart and the vascular system. The heart pumps blood and it goes through pipes or tubes, which are the blood vessels that take this blood to our cells, our organs, to feed them. And then after the organs use blood, there's a different set of blood vessels called the veins that redirect this blood back to the heart to complete the cycle. So we're talking about all of that. So let's start. You know, we'll start with the common things first. Everybody here knows about high blood pressure or hypertension. And hypertension, unfortunately, is very prevalent in our society among us Black people also. So it's very important that we pay attention to stuff like this. So when we talk about high blood pressure, we're talking about the pressure with which, blood travels through our vascular system. And if the pressure is too high, it leads to a lot of damage. And we're going to talk about this as we proceed along. So when we talk about high blood pressure, what do we mean when we say somebody has normal blood pressure? So normal blood pressure is when your blood pressure is less than 120/80. So the number on top is called the systolic blood pressure, and the number on is called the diastolic blood pressure. So normal blood pressure is less than 120/80. Now, when your blood pressure is a little higher than 120/80, so between 120 to 130 systolic and 80 diastolic, we say you have elevated blood pressure. Elevated blood pressure. If your blood pressure is higher than 130/80, then you have high blood pressure. And this is a new definition because in the past, the numbers were a little higher than 130/80 to say somebody has high blood pressure.
140/90.
So at what point do we begin to treat high blood pressure? Now, we usually will start treatment with blood pressure medications if your blood pressure is more than 130/80 and you are a diabetic, or you have kidney disease, or you've had a stroke before, or you've had a heart attack before, you have coronary artery disease. And also, we have a special calculator where we are able to calculate a person's risk for developing heart attack or stroke in the next 10 years. This is called a 10-year ASCVD risk calculator. So we plug in numbers. So we look at your age, your sex, your race, your cholesterol profile, we put in your blood pressure, and then the calculator tells us what is your risk for developing heart attack or a stroke in the next 10 years. And if your risk is more than 10%, it means that if we take 100 people just like you with the same numbers in terms of cholesterol profile, blood pressure, age, sex, race, and everything, if we take 100 of you and we follow you for the next 10 years, and 10 of you or more will develop heart attack or stroke, it means that's high. And you're at high risk, and therefore we should start treating you at lower blood pressure. So if your blood pressure is more than 130/80 and you're diabetic, or you have chronic kidney disease, you've had stroke or heart attack, or you have coronary artery disease, or you have a very high risk for developing cardiovascular disease, then we will start treating you when your blood pressure is more than 130/80. If you do not belong to any of these categories, then we will treat you when your blood pressure is more than 140/90. So for the regular person who's never had a heart attack or stroke, doesn't have kidney disease or diabetes, we only treat when your blood pressure is above 140/90. And concurrent with medical treatment is always lifestyle changes, lifestyle modifications. And we'll go into details of lifestyle modification, but generally it involves exercise, eating a heart-healthy diet, low-salt diet. And when we say low-salt diet, we're talking about consuming less than 2 grams of sodium a day. Dietary supplementation with potassium, that's good. Moderation of alcohol, because alcohol can raise your blood pressure. Alcohol can cause a lot of other deleterious cardiovascular effects, which we're going to talk about in the course of this discussion. And when you're a hypertensive patient and you're on treatment for high blood pressure, our goal blood pressure is to keep you below 130/80. So if you're on medications, we want to keep you on average below 130/80. If you stay above 130/80, you're not well controlled, and we might make further adjustments to your medication. So that's for blood pressure. Now let's touch on coronary artery disease. Now when we talk about coronary arteries, we're talking about the arteries that supply blood to the heart muscle. So if this is your heart, this is a major blood vessel called the aorta. Now, coming off of the aorta are 3 major blood vessels that supply the heart muscles. So we call this the left main coronary artery. It splits into the left anterior descending artery, the left circumflex, which supplies the left side of the heart. The left anterior descending supplies the front part of the heart. And then you have the right coronary artery that supplies the right side of the heart, and usually also the bottom of the heart. If you have blockage in any of these arteries, you can have, if you have blockage in any of these arteries, we call it coronary artery disease. Or if you have plaque buildup in any of these arteries, we call it coronary artery disease. And coronary artery disease can present variedly, and we want to go into the details of how does it present? How do you know you might have coronary disease and take it seriously enough to have somebody check you out? So there's something we call angina or angina. Angina or angina is chest pain. Chest pain, there's so many causes of chest pain, and chest pain can present in many different ways. But the kind of chest pain we call angina is chest pain due to poor blood flow to your heart muscles because there is narrowing in the blood vessels that supply the heart muscle. So, and this can present on a chronic basis. Sometimes you can, so the way it presents is somebody will have chest pain on, say, walking a block or 2 blocks. And this chest pain typically is described as pressure-like, or like something on your chest, like an elephant on your chest. And in some cases, this chest pain may radiate to, say, the jaw or the neck. It may go to the shoulder, maybe the left shoulder, or it may go into the left arm. You know, some people may go into the right arm. And typically, it is provoked by exertion. So physical exertion or emotional exertion. You may get excited, you're angry with somebody, and then you have chest pain. It feels like pressure, like something sitting on your chest. This is what we call angina or angina. So chronic stable angina is predictable. You may walk a block, 2 blocks, you get chest pain. And when you stop to rest, the chest pain relieves. That is chronic stable angina. And chest pain can also relieve what we call sublingual nitroglycerin. So if you go to the emergency room, they may put a medication under your tongue that can help relieve the chest pain. So the characteristics of an anginal type pain is provoked by exertion or emotion and is relieved by rest or sublingual nitroglycerin. Now, unstable angina is, for example, when you have chronic stable angina, that kind of predictable angina that occurs after exertion and is relieved by rest, it may get to a point where it gets worse. For example, if at background, your chest pain occurs on walking 2 blocks, and now you take maybe just half a block, you have chest pain, it means your angina is getting worse. So we call it unstable at that point. Unstable angina can also mean having rest pain. So you're just there, you're doing nothing to provoke it, but all of a sudden you just get this chest pain, pressure like something sitting on your chest. It may radiate to your jaws, like we talked about. And this chest pain may be associated with shortness of breath, may be associated with breaking out in cold sweat, or your heart beating fast, stuff like that. It's all, angina. So when it happens like that, at rest is unstable angina. Or if you have chronic stable angina, it's getting worse over time. And unstable angina can also be seen in terms of somebody has chest pain suggestive of angina, they come to the emergency room and you do blood work, you look for cardiac enzymes, you do EKG, and you don't find any significant changes on EKG and the blood work is negative. Yeah, and as long as the chest pain is typical of angina, we call it unstable angina and we treat it as such. Now, myocardial infarction or heart attack, as we all know it, is when you have, and I'm going to go into the details of that on the next slide, is when you have, say, blockage in your artery that disrupts blood flow to the muscles that the artery supply, and the muscles kind of die or infarct. That's when you have a heart attack. And it presents similarly, like we said, chest pain, it may be crashing, it may be pressure-like, and you're short of breath, palpitations, you're breaking out the cold sweat, that sort of thing. So that may also be a sign of myocardial infarction. Like those that will do EKG, we check some blood work. We may end up going to the cath lab and demonstrate that you have blockage, and then open the blockage up with like a stent or something like that. Now, so this is how atherosclerosis develops. So as you can see in this picture here, you have this artery, you have this nice artery over here. Over time, from the day we're born, over time, plaque builds up to coat the inside of the vessel lumen. So plaque is coating the inside. And this plaque grows over time, as plaque is lining the lumen or the inside of this vessel, it grows over time, and it gets to a point where this plaque is unstable and it may rupture, it may break. And when the plaque breaks or ruptures, blood that comes in contact with the plaque will form a blood clot. And this blood clot can occlude or block the artery and prevent blood flow to the heart muscle. And this is what causes a heart attack or myocardial infarction, because it can kill off the heart muscle that is supplied by this blood vessel. All right. And you can see this slide also, right?
Yeah, we can.
Yes.
All right. So when we talk about myocardial infarction, as you can see in the picture here, you have plaque that breaks off, you have a big blood clot that disrupts blood flow to the heart muscle, and this can lead to a damage in this heart muscle. So like we said, results from occlusion of blood vessels to the heart muscle, and it presents like we described already, right? Chest pain. But I want you to understand this, that it's not every patient who reads the textbook. It's not every patient who will present as described in the textbook. Some patients may have chest pain, which is not exactly typical as we know it for angina. It may not be an elephant sitting on the chest. It may not be pressure. In some people, it may just be heartburn. It may feel like gas, like heartburn, In some people, they may just have only shortness of breath and no chest pain. But this shortness of breath can be what we call an anginal equivalent. And like we said, there may be associated symptoms of this angina. There may be numbness in the arms, sweating, palpitations, etc. So when you get in things like chest pain on exertion, you gotta pay attention to that. You gotta take it seriously and get it checked. Okay, what are the risk factors for coronary artery disease? Who stands a risk of developing coronary artery disease? Now, these are the traditional risk factors for coronary artery disease. Age, as we age, our risk for developing heart disease goes up. So for males more than 45 years of age, or females more than 55 years of age, your risk for developing coronary artery disease actually goes up. Now, when you have a family history of premature heart disease, that also will raise your personal risk of heart disease or coronary artery disease. What do we mean by positive family history or significant family history of premature heart disease? Now, if you have a first-degree relative who is male and developed heart disease before the age of 55, that is considered significant. And what do we mean by first-degree relatives? We're talking about your siblings, your brothers, sisters, your parents. Well, your aunt, your uncle, your grandfather, not so much, And if you have a first-degree female relative who has or who develops heart disease before the age of 65 years, that's also considered a significant family history of heart disease, and that can also increase your risk for developing heart disease. Obesity. Obesity is an important risk factor for developing coronary artery disease. I mean, for other conditions also, like high blood pressure, diabetes, and stuff like that. And what do we mean when we say obesity? Obesity, we have a metric we call body mass index, or BMI, where we check your weight and divide that by your height squared, and that gives us a number for your BMI. And roughly 20 to 25 is considered normal BMI. From 25 to 29.5, thereabouts, is considered overweight. 30 and above is considered obese. So obesity, is associated with a lot of, that's not good. If your BMI is less than 20, that's not good also. If you can keep yourself in the normal range, that's fine. High blood pressure is a risk factor for developing coronary artery disease. Tobacco smoking, if you smoke cigarettes, that is a risk factor for developing coronary artery disease. In fact, there's nothing good about smoking, so we outright encourage our patients to quit smoking, you know. Sedentary lifestyle. Sedentary lifestyle, you sit at one place like a couch potato. You don't move, you don't do stuff. All these things increase your risk for coronary artery disease. High cholesterol will increase your risk for coronary artery disease as well. Hyperlipidemia is what we call it. So if you want to decrease your risk for coronary artery disease, there's some things you can change and some things you cannot change. Obviously, you cannot change your age or your family history, but you can do something about your weight. You can treat your high blood pressure if you have it. You can quit smoking. You can move some more, and you can control your cholesterol if you have it, or you can, you know, that sort of thing. All right. Now let's shift our attention to a condition we call heart failure. So heart failure is when the heart cannot pump enough blood to meet the needs of the body. The heart cannot do that. We say there is heart failure. So heart failure can be seen in terms of two aspects. We have, is the heart strong enough to pump blood to reach the organs, the cells, the tissues, to meet the needs of the body? Or the heart may be strong enough to pump all right, but it may be stiff and not relax well to take in blood that is coming in to be able to pump it in the next beat. So if your heart is weak and it's not pumping enough, blood is going to accumulate and stuff is going to back up in your lungs, make you short of breath. You're going to have leg swellings and stuff like that. Your heart may be strong. So that type of heart failure, the first one is called systolic heart failure. Or your heart is strong enough, it's squeezing and pumping all right, but it's not relaxing well to take in blood. We call it diastolic heart failure. And that can also lead to blood backing up, you know, fluid in your lungs and legs swollen and stuff like that. So how does heart failure present? How do we know we might be having symptoms of heart failure? Now, it presents commonly as shortness of breath at rest or on exertion. So when you walk a little bit and you're short of breath, you gotta stop and catch your breath. That is not normal. It may not even be normal for you. You know, something is going on. If you're short of breath on lying flat on your back, say if you lie on your back, you ought to be able to breathe well. But if you cannot breathe and you have to lie propped up, say you need like 3-4 pillows, be comfortable to be able to breathe well, that is a problem. It means fluid is backing up in your lungs. That's why you cannot breathe when you lie flat. If you sit up, then the fluid drains to the dependent portions and the upper part of your lungs can take in air and you breathe better. Yeah, so if you cannot lie flat because of shortness of breath, that may be a sign of heart failure. Sometimes cough may be a sign of heart failure because of fluid in your lungs. So cough can come from many other conditions, right? You may have, say, pneumonia and get cough. You may have other conditions and get cough, but cough can also be a sign of heart failure. When we say nocturia, we're talking about, you know, waking up excessively at bedtime to urinate. Yeah, that can be a sign of heart failure, but heart failure is not the only cause of nocturia. Fatigue, maybe fatigue at rest or fatigue on exertion. So you may exert yourself minimally and you're so tired. This may be a symptom of heart failure. Leg swelling, so you have leg swellings. And sometimes you press on it, it indents, you know, it fits. That is a sign of fluid in your legs. And it's because of fluid accumulation from heart failure. The common causes of heart failure are the risk factors that can predispose you to heart failure. Again, high blood pressure. So you can see high blood pressure is not a very good actor. It's a bad actor, right? We see that high blood pressure can cause coronary artery disease. And now we're learning also it can lead to heart failure. So initially, you know, because your blood pressure is so high, your heart is struggling to pump blood into those arteries. So your heart muscles get thick You get thin, they may still be pumping strong, but they may become stiff as a result. They may not relax well, and that can also lead to the kind of heart failure we call diastolic heart failure. And over time, if the blood pressure is not controlled, the heart would tire. It would tire at a point where it now becomes weak, so it becomes systolic. So the heart will burn out, you know. Other causes of heart failure will be coronary artery disease. Remember we said, if you have coronary artery disease and there is blockage to the heart muscles, those heart muscles can die, can get damaged. And when the heart muscles die, the heart becomes weak. It just cannot pump enough. It can't do its function well, and you will have heart failure. Sometimes abnormal heart rhythms can predispose you to heart failure, like atrial fibrillation, which we're going to talk about shortly. Diseases like diabetes, etc., can also predispose you to heart failure. Now here, let me turn my attention to heart rhythm abnormalities. Heart rhythm abnormalities. I think the commonest ones will be what we call atrial fibrillation and atrial flutter. So, you know, under normal circumstances, the heart beats in a regular, coordinated way. So I put this EKG here to say heart is beating regularly, things are going fine, normal cardiac rhythm. In atrial fibrillation, you have irregular heartbeat. So things are so chaotic, everything is just beating so irregularly. Now, what is happening here is, so generally what happens is, you know, the heart has 4 chambers, you know, 2 on the right, 2 on the left, 2 on top, 2 at the bottom. So the top chambers are called the atria, and the bottom chambers are the ventricles. So the one on the right side we call right ventricle, the one on the left side we call left ventricle. So under normal circumstances, when the electrical activation of the heart to cause your heart to beat, it starts from the top, you know, the right atrium, and then, you know, electricity passes down and goes to the bottom. Now, and everything is done in a coordinated way. So first of all, the heart relaxes, it takes in blood passively, and then the top chambers will contract or squeeze and add more blood before the bottom chamber squeezes to pump the blood to the rest of the body. Now, in atrial fibrillation, there's no organized contraction of the top chambers, the atria, the top chambers. And therefore, you miss out on the atrial contribution of blood to your overall cardiac output. You know, you could be missing 20, 30% of overall cardiac output. And that may not be enough for a lot of people and may cause them to become short of breath, especially when they exert themselves. So in atrial fibrillation, you have, you know, no coordinated electrical activity in the atrium. And because the atria, the top chambers, are not really squeezing, they just kind of quivering around, blood hangs around, and it can form a blood clot. If blood is not moving, it stagnates, it can clot. And the commonest place where blood clots is called the left atrial appendage. And the left atrium is the top left chamber. That has an earlobe on the side, and if the atrium is not beating and blood accumulates in this atrium, this earlobe or the appendage, it can clot. And when it clots, it can break off and get pumped to the rest of the body. It can go to the brain and cause a stroke. It may go to your abdomen and cause infarction of your bowel, or it may go into your legs and cause an acute limb ischemia. And if you're not careful, you could lose your limb as a result of that. So atrial fibrillation can cause stroke. It can cause, you know, other dangerous conditions as a result of blood clot formation and that blood clot breaking off and getting pumped to your body, to your brain and other places. So sometimes some people may not have any symptoms at all. They may be in atrial fibrillation and not even know it. But commonly though, it may present as fast heartbeat. You feel your heart beating fast, you have palpitations, and this may be fast and irregular palpitations. If you have things like this, it's better to get it checked out. So it may present as irregular palpitations. It may also present as shortness of breath. You're just short of breath, either at rest or when you exert yourself. So you're walking, oh, you're short of breath, more than usual. And you don't understand that. It could be because you have atrial fibrillation. It could be because of heart failure, remember? It could also be because you have coronary artery disease. So all these things can be common, right? Symptoms can be common to all these disease entities. It may be hard for you to sort out in the comfort of your home. You got to come, and even we also have difficulty at times sorting it out. But we have the advantage, and we have some tools in our armamentarium that we can use to help us sort it out in terms of investigations and stuff like that. Fatigue may be another presentation of atrial fibrillation. And like we said, the complications of atrial fibrillation may be stroke, maybe embolism means when a stroke, when the blood clot breaks off and goes to other parts of the body to cause damage. Or, and we said earlier on that atrial fibrillation can cause heart failure. If your heart is beating so fast for a long time, it can become weak. So you can have systolic heart failure as a result of uncontrolled atrial fibrillation. This is what we call tachycardia-mediated cardiomyopathy. So again, what are some of the causes of atrial fibrillation? High blood pressure can lead to atrial fibrillation. Coronary artery disease can lead to atrial fibrillation. Alcohol consumption can lead to atrial fibrillation. There's something we call holiday heart syndrome. So typically occurs on the weekend, on Saturday or so, when a patient sits down and drinks binge intake of alcohol, you know, and then they come with acute onset of atrial fibrillation with very fast heartbeat. Yeah, so alcohol can lead to atrial fibrillation. Heart valve disease, for example, when you have tightness of this valve on the left side called the mitral valve. So the mitral valve, so you can think of the heart valves like a gate that open in one direction to allow blood to flow. So for example, the mitral valve opens to allow blood to flow from the top left chamber to the bottom left chamber. It is the bottom left chamber that is the main pump of the heart. That is the left ventricle. It is that squeezes to pump blood to the rest of the body. So this mitral valve will open, allow blood to go down, and then it will close to allow for blood to go forward instead of flowing backwards into the top left chamber. Now, when you have tightness of the mitral valve, it's called mitral stenosis. It means the valve is not opening wide enough to allow blood to flow down. Yeah, this can cause blood to accumulate in the left atrium, causing it to stretch out and trigger atrial fibrillation. Diseases like thyroid disease, hyperthyroidism, overactive thyroid gland can predispose you to atrial fibrillation. And when you control the thyroid disease, atrial fibrillation resolves, you know? So direct causes, if you control, say, alcohol intake, or even obesity has been shown to be associated with atrial fibrillation. And if you lose weight, it can reduce your atrial fibrillation burden, you know? Now let's move to stroke. Everybody has heard of stroke. Stroke or cerebrovascular accident, CVA. So cerebrovascular accident is injury to your brain cells or your brain tissues as a result of disruption of blood flow to the brain. And there are two main types. It can be because there is blockage in the arteries that supply the brain, leading to lack of blood flow to the brain and death of brain cells, much as you see in heart attack, right? Or myocardial infarction. Or it could be that either due to blood vessel abnormalities or high blood pressures, the blood vessels may rupture, they may break, and then blood leaks into the brain tissue, causing direct damage as a result of that. How does stroke present? You know, it may present as maybe a speech impairment. Somebody may have difficulty speaking, or sometimes they can speak, but as it makes sense, they don't understand. That's called, you may have expressive aphasia or receptive aphasia. You may have weakness on one side of the body, weakness on the face, and that may result in, say, when they smile, their mouth twists to one side. They may not be able to wrinkle their forehead or close their eyes shut. You know, when they smile, you know, like we said, the mouth will twist to one side. It may also present as numbness on the face or the arm, the body itself, the torso, or the legs. Now, when you have this, I cannot say this, I cannot emphasize this enough. You know, stroke that is due to blockage, there's good treatment for it. If you present early enough, we can give medicines that are clot busters. It will break the clot and restore blood flow to the brain, and it can actually save your brain cells, you know. If you do it early enough, it's a lot of patients that walk out of the hospital like they had, like nothing happened. But if you sit on it for too long, then that window closes. The window for us to be able to bust that clot will close, you know. So it's very important when you have things like this. Sometimes there's something we call transient ischemic attacks, or TIA. These are mini strokes that may happen, and it's a warning of a future stroke. So you may have, say, transient blindness in one eye, like a curtain of darkness going over one eye, and it resolves pretty quickly. Or you may have difficulty speaking that resolves within an hour or less. Or you may have weakness on one side, or your mouth twisting to one side that resolves early enough. These are called mini strokes or transient ischemic attacks. Do not think you're good because you feel better now. It is a warning, it's a harbinger of future stroke. So when you have things like this, you better go to the hospital and get checked, you know, and then we can institute treatment that will prevent you from having stroke in the future. Again, what are the risk factors for stroke? The same actors, right? High blood pressure, high cholesterol. Remember, when cholesterol coats the inside of the vessels, like you have here, you know, this leads to narrowing. When there's a plaque rupture, just like you have in heart attack, and blood comes in contact with it, it can form a blood clot that blocks blood flow to your brain cells, and this can lead to stroke. So high cholesterol, diabetes, you know, diabetes is a vascular disease, you know, it causes atherosclerosis or hardening or plaque buildup in your arteries. Smoking does the same to your blood vessels, you know. Sometimes some people have brain aneurysms, which may be like saccular or sac or outpouching of these blood vessels in the brain, and they are weak and they can rupture or break off and cause bleeding into the brain. Or you may have what we call arteriovenous malformations. So abnormal communications between small arteries and veins, and these communications are weak vessels, and they could rupture at any time and cause bleeding into your brain. And these can be catastrophic events if you're not lucky, or if you do not seek, or if help does not reach you quick enough, you know. Clotting disorders. Some people have clotting disorders. The blood clots quite easily. And if your blood clots, it can clot and block blood flow to your brain, and you get a stroke, you know. It can clot and block blood flow to your legs. You get either a deep vein thrombosis or an arterial thrombosis, stuff like that. Some people also have rheumatologic diseases like systemic lupus, erythematosus, and other rheumatologic diseases. These predispose the clot formation or atherosclerosis in arteries. Arteries around the heart, arteries going to the brain and other major organs like the kidneys and stuff, and all these can cause disease. Yeah, I'm going to slow down a little bit. I hope I'm not going too fast. It's a lot of concepts, a lot of subject areas I'm introducing, but I think, in my opinion, these are the areas that we should pay particular attention to, so that if we're having symptoms like this, we can seek the care that we need, so these conditions can be taken care of before they cause more harm or damage to us. Now, peripheral arterial disease. So, you know, like we said, the heart, the cardiovascular system is made up of the heart as the main pump, And this heart pumps blood to the body's organs through special tubes or blood vessels. Now, the arteries are the blood vessels through which the heart pumps blood, and they carry oxygenated blood or blood that has oxygen and nutrients to the body. And when the body uses up all these nutrients from the blood, blood accumulates back into the veins or the venous system. And these veins redirect blood to the right side of the heart, which pumps it to the lungs to get oxygen. It comes back to the left side of the heart, which pumps into the rest of the body. So you have a continuous circuit, you know? So because it's one continuous tubing, one continuous system, if you have, say, blockage in your heart arteries, it's very likely you could have blockage in, or if you have atherosclerosis or hardening or plaque buildup in your heart arteries, it's very likely you could have plaque buildup in the arteries going to your brain, you know, or the arteries going to your legs or to your bowel, you know, that affect digestion and stuff like that, you know. So people who have coronary artery disease could very well have peripheral arterial disease. And peripheral arterial disease also is the same mechanism where you have plaque buildup inside the lumen of the blood vessels, causing narrowing and thereby restricting blood flow. Now, when you have blockage or narrowing of your leg arteries, thereby restricting blood flow to your legs, the way it presents is you're going to have pain when you walk. So you may have pain in your calf, your thigh, or your buttock when you walk. And this pain will be relieved when you stop walking, when you rest. This is what we call claudication. So if you're walking and you get pain and that pain stops after stopping or resting, it's a symptom or it's a symptom of possible blockage in the arteries going to your legs. We call it claudication. So take that seriously, have it checked. Now, in advanced cases where there's more advanced peripheral arterial disease, you may even have pain at rest, not only provoked on walking, but it's at rest. When you have pain at rest, that is a bad sign. It's a sign of critical limb ischemia or critical decrease in blood flow to your legs, and therefore you should have that checked because it can lead to limb loss. You know, if these things are not checked and the vessel completely occludes, the tissues die, then you will have no option than to have amputation. But if you get it checked early, we can go in and open these vessels up, you know, non-surgically by, you know, ballooning it to open up the lumen so blood can flow again. Sometimes we put in stents, as we do in heart vessels, or in cases that is not doable that way, you can have bypass of your leg arteries as you do bypass of your heart arteries, you know. So it's very important to pay attention to this. Sometimes you may have cold feet. Cold feet, if it happens acutely, it's a bad sign. It's a sign of critical limb ischemia. Can lead to limb loss. We treat it much the same way as we would treat like a heart attack, because if you don't act on it quickly, it can lead to limb loss and amputation. Sometimes you have ulcers that do not heal. They do not heal because they're not getting enough blood flow that will bring in the nutrients that they need to heal. So if you have a non-healing foot ulcer, this may be a sign that you have peripheral arterial disease. And the only way that ulcer can heal is when you restore blood flow by opening up that blockage. So it's very important. Acute limb ischemia we talked about is to be treated like a heart attack because it can lead to limb loss. So, you know, there's simple ways that we screen for peripheral arterial disease, simple tests. We do something called ABI, or ankle brachial index, where we measure blood pressure in your arms and in your legs, and we divide one by another, and we get a number, and that number tells us if you have peripheral arterial disease, and it tells us the degree to which your peripheral arterial disease is serious. Is it mild disease, moderate disease, severe disease, you know? We can use ultrasound very much the same way as we use ultrasound to image the heart. We can use ultrasound to image the blood vessels of your legs or of your extremities to see if there is blockage in those arteries. Sometimes we do angiogram where we do a CT scan, but we inject dye and take picture that because the dye would delineate the artery so we can see whether there's blockage in the arteries or not. We can do peripheral angiogram in the cath lab and stuff like that. Now, I have said a lot of things, but I think the most important thing is, well, who cares? Yeah, we do care. But what can we do to prevent heart disease, right? That is the major take-home point. What can we do? It's very important to know the symptoms so you can identify when things are going wrong and seek care. But also, what can you do to prevent heart disease? You know, and these are simple things like lifestyle changes. How do we change our lifestyle? When we talk about lifestyle changes, we look at it in terms of diet, in terms of exercise, weight loss, quitting smoking, moderation of alcohol. So now let's delve into diet, you know, and I'm sure a lot of you have very interesting questions to ask me about diet. Again, we are Africans, we have our own diet, but we have to look into our diet and see which ones are good for us and which ones are not so good, you know, and avoid the ones that are not good for us. Our diet should be rich in vegetables, fruits, nuts, legumes, whole grains, lean meat. Lean meat, like say chicken without the skin, you know, fish. These are healthy diet, you know. Red meat is not good. Red meat is harmful in many ways to your cardiovascular system. Red meat has solid fats. Solid fats are not good, and I'll talk about those. Solid fats are not good for you. So you want to limit your intake of red meat, like beef, you know, deer, lamb, all this stuff. You want to decrease your intake of this because it has some bad nutrients over there that are not good for your overall health. So minimize the intake of red meat. Processed meat, no good. Processed meat is a waste. Now, processed meat, number one, it can cause cancer of the GI tract. It can cause heart disease, strokes, etc., etc. Refined carbohydrates. You want to minimize the intake of refined carbohydrates and sweetened beverages. You know, I don't know if any of you live in the South, but in the South, and I lived in the South before, and when you go to a restaurant and you want iced tea, you know, in DC and all those Maryland and places, you just say you want iced tea, they bring you iced tea. It's on sweet, right? But in the South, you say you want iced tea, and the next question is sweet or unsweet, you know? And the sweet one is not good. Sweetened beverages are not good. You want to avoid trans fats. What are trans fats? So generally, so see, fat can be good for you, right? Your body needs fats to function. The nerve function needs fats. Your brain needs some fat to function. And there's some vitamins that have to dissolve in fat for your body to be able to utilize them. So they're good fats, but they're also bad fats. And we need to be able to recognize this and try to avoid or limit as much as possible. Now, when it comes to trans fats, you want to avoid that altogether because it's very, very harmful fat. So when we say bad fats, those are usually your trans fats and your saturated fats. So bad fats are usually fats that are solid at room temperature. So when you have fat that is solid at room temperature, those are the bad ones, the trans fats and the saturated fats. So for example, coconut oil is usually solid at room temperature. Or the fat that comes with red meat, you know, like the fat that comes with beef and lamb and deer, all those are bad fats, you know, they're solid. Cheese, dairy products, the fats, some of those fats are in milk and cheese and all those kinds of things. Now, so you want to avoid that. Trans fats, usually there's a small amount of trans fats in say, red meat, in say, beef or lamb or deer meat. But when we encounter trans fats, is usually because of processing of regular oils or vegetable oils to make them more stable and more durable And so restaurants use them, and it's through a process called hydrogenation. So when you buy a product and you look at the label and it says partial hydrogenation, you should avoid that like a plague. So the partial hydrogenation is what turns these oils into trans fats. And trans fats, what they do to your body is they increase your bad cholesterol, which is your LDL. LDL cholesterol, as we'll talk about very soon, is the bad cholesterol, is the kind of cholesterol that coats the inside of your blood vessels and lead to the plaque buildup that we talked about, which can rupture and cause a heart attack, you know? So the bad cholesterol goes up when you take bad fats like trans fats and saturated fats, and it decreases your good cholesterol. Your good cholesterol is called HDL, high density lipoprotein. Now, HDL, the way it works is it goes inside the blood vessels and mobilizes the bad fats, the LDL, you know, and transports them to the liver for disposal. So if you have a decent amount of good cholesterol, that is beneficial. And if you have a high amount of bad cholesterol, that's no good. Now, what these saturated fats do is they increase your bad cholesterol, decrease your good cholesterol, and they also raise your triglycerides. So triglycerides is another type of cholesterol that also is harmful to your cardiovascular health. So now, what about saturated fats? Saturated fats can be found in, like I said, oils that are solid at room temperature. You know, you find them in the same fats that are associated with red meat. You know, palm oil, the one that we drink or we use for our cooking, jomi. Palm oil is kind of neutral because it's 50% saturated fats and 50% unsaturated fats. But say coconut oil is more saturated fat, you know, about 80 to 90% saturated fat. It's not good. Palm kernel oil, right? Palm kernel oil is different from palm oil. Palm kernel oil also has a higher percentage of saturated fat. So that's also not very healthy. But oils like olive oil, canola oil, you know, avocado oil, those oils are liquid at room temperature. Those are good oils. Those have what we call unsaturated fats. So unsaturated fats are more beneficial to us because they raise your good cholesterol, HDL, they decrease your bad cholesterol, LDL, and they decrease your triglycerides as well. So they actually give you benefits. So if you want to use oil, use olive oil, use those vegetable oils, you know, like canola oil, oils that are liquid at room temperature. Okay, so you want your diet to have low cholesterol and low sodium. Remember, we said if you take too much sodium and you have high blood pressure, it's very difficult to control. And one of the ways we control blood pressure is to decrease our sodium intake to less than 2 grams a day. All right, also caloric restriction. If you're overweight and obese, you want to decrease your calorie intake to promote weight loss. And this will translate into cardiovascular benefits. Now, moving from diet, we move to exercise, also as part of our lifestyle changes or lifestyle modification. So exercise, when we say exercise, what do we mean? What kind of exercise is beneficial to our heart? Now, we recommend what we call aerobic exercise. Aerobic exercise is the repetitive exercise that leads to increased heart rate and increased breathing rate, like walking and brisk walking, swimming, running, you know, all those are considered aerobic exercises. And the recommendation, according to our American Heart Association, American College of Cardiology, is we should strive for about 150 minutes of moderate intensity exercise when you add it all up over the course of a week. So this will come to about, say, 30, 35 minutes of exercise most week, you know, like 5 days of the week or more. That can put you in that range. Now, for those who are busy and cannot exercise on a daily basis, the recommendation is if you can do vigorous intensity aerobic exercise up to about 75 minutes a week, that also will give you the same benefit like if you did moderate intensity or about 150 minutes over the course of a week. Now, sometimes we're busy, myself inclusive. I don't always make time to exercise, particularly when it's cold like this now. But again, any amount of exercise is better than no exercise. So when I go to work, sometimes I'm minded to take the stairs instead of taking the elevator. So at least you put in something, you walk, you put in some amount of exercise. Now, so we talked about aerobic exercise, but to complement this, you want to do a little bit of resistance training or weight training. So you want to add a little bit of weight to your aerobic exercise. And studies have shown that this will improve your physical functioning. It can improve diabetes control and possibly lower your blood pressure. So you want to reduce sedentary lifestyle, right? You want to get up and keep moving, do something instead of sitting in the couch watching Netflix all day, you know? Weight loss. Let me tell you, do not set unrealistic goals for yourself when it comes to weight loss. Chances are you may not be able to achieve it. There is body of data to show that if we are able to lose just 5 to 10% of our initial body weight, we stand to improve our blood pressure a lot. We can delay the onset of type 2 diabetes. We can even improve diabetes control and also improve cholesterol control, you know? So if say you weigh 300 pounds, just set for yourself a goal. I want to lose 30 pounds. Don't say I want to lose 100 pounds. That is unrealistic. You may not be able to achieve that. So just set for yourself a goal of losing 5 to 10%, and you're going to stand to derive a lot of cardiovascular benefits doing that. And then once you achieve that, you can set a new goal for yourself if you want, you know? Calorie restriction. So we're saying if you're overweight, you're obese, you want to restrict your calories. So generally you want to say, okay, I want to reduce my caloric intake by 500 kilocal less than my total calorie consumption, you know? So, you know, for women, and this may be very tight, these recommendations may be very tight, you may be hungry doing this, but say women, we say 1,200 to 1,500 kilocal a day. And for men, 1,500 to 1,800 kilocal a day will be a good calorie zone to be in, calorie consumption zone to be in. Yes, lifestyle modification. We're still on lifestyle modification. It's such a big topic, and the effects can be very, very beneficial. Smoking cessation. If you smoke, we want you to stop because smoking causes cardiovascular disease. Smoking can cause blockage in your leg arteries, make you lose your limb. Smoking can cause heart attack, can cause stroke, all manner of bad stuff. It burns a hole in your pocket too, right? So you want to quit smoking. It can be hard because, you know, once you form certain habits, it may be hard to quit. So sometimes we help patients by giving them medications that can help them to quit smoking. Sometimes they're able to do it cold turkey on their own, which is fine. More power to you if you're able to do that. We also advise moderation of alcohol intake. What do we mean by moderation of alcohol? Let me be very honest with you. No amount of alcohol is actually safe, all right? Alcohol causes cancer to your GI tract like that. But we do also know that alcohol in moderation can have some beneficial effects to your cardiovascular health. Alcohol in moderation can raise your good cholesterol, you know, and that, like we explained before, can help mobilize bad cholesterol, right? Send it to the liver for disposal, yeah, and actually improve your cardiovascular health. So what do we mean by moderate alcohol intake? When we say moderate alcohol intake, for men, we say no more than 2 drinks per day. And for women, no more than 1 drink per day. So what is 1 drink? What is the metric for 1 drink? Now, it depends on the kind of alcohol you're consuming. For wine, a glass of wine is considered 1 drink. And when we say a glass of wine, we're not talking about filling the glass to the brim, you know, you just keep it in the middle there. That's 1 drink. So for men, you don't want to drink more than 2 in a day. For women, you don't want to drink more than 1 in a day. Now, if it is hard liquor you're drinking, hard liquor, a shot of hard liquor is considered 1 drink. So a shot of hard liquor is considered 1 drink. Again, those are the metrics, no more than 1 for females, no more than 2 for males. If you're talking about beer, then if you take the 300cc can of beer, that's considered one drink. A 300 mils can is considered one drink. So again, we talked about wine, we talked about hard liquor, we talked about beer. So those are your metrics. That's how you measure yourself. But this is what you should not do. You should not say, oh yeah, I'm going to abstain from Monday to Friday because I go to work. And then I'm going to be the weekend warrior where I'm going to sit on a Saturday and I'm going to add it all up and I'm going to binge drink. So I'm going to say, okay, I'm entitled to drink 2 drinks per day times 7, that's 14 drinks. And therefore, since I abstain from Monday to Friday, I'm going to sit down on a Sunday or Saturday and drink 14 drinks. That's binge drinking. It's not good. It's very harmful. It can cause what we said, atrial fibrillation, right? Cause heart failure and all those kinds of things. So the benefit of alcohol is in regular intake, not being the weekend warrior, binge drinking. That does not give you the benefit. But like I said, no amount of alcohol is safe. There are other deleterious effects of alcohol beyond the benefit to your heart, But again, alcohol can cause hypertension, can cause heart failure, atrial fibrillation, and stuff like that. So you want to be very moderate in alcohol intake. If you don't want to drink it, that's fine. More power to you. And then how do we prevent heart disease once you get it? Now, if you have high blood pressure, you want to see your doctor, right? On at least once a year basis, they check your blood pressure, they do some blood work, they check you for diabetes, check you for high cholesterol. And if you have any of this, they treat it. Because if you treat blood pressure, then you can prevent heart failure, you can prevent stroke, you can prevent heart attack, If you treat diabetes, you prevent all the complications that can arise out of diabetes. If you have atrial fibrillation, it should be properly treated, particularly paying attention to stroke prevention. Remember, we said that if you have atrial fibrillation, you can form blood clots in your heart, which can break off, go to your brain and cause a stroke. So when you have atrial fibrillation, we determine your risk for stroke and put you on blood thinners, in addition to controlling your heart rate or putting you back into normal rhythm. We also give blood thinners to prevent stroke in people who qualify. Not everybody does. If you're 35 years old and you don't have diabetes, you don't have hypertension, you've never had a stroke or mini stroke, you don't have any other condition, you have atrial fibrillation, your risk for stroke is low. So you may not qualify for blood thinners. But other people will if they have hypertension, diabetes, heart failure, they've had a stroke or mini stroke before, or if their age is more than 65 years, So atrial fibrillation has to be appropriately treated to prevent stroke rates. People have what we call obstructive sleep apnea, where it's not all snoring that is obstructive sleep apnea, but major part of it is where people will snore, they may stop breathing at night. People who sleep with your partner may tell you, they notice that you've stopped breathing. They wake you up, then you start breathing again. That may be a sign of obstructive sleep apnea, which means that when you sleep, the tongue falls back and obstructs the airway, obstructing air going into your lungs. So you will starve of air and then you wake up, to breathe again. That is, sometimes you don't even know you're waking up. These are called micro arousals. And you wake up and you're not well rested because your sleep has been interrupted multiple times by waking up, which sometimes you don't even know you're waking up. And so you'll be tired during the day, maybe sleepy during the day. Those all may be signs of sleep apnea. So usually when people are obese, they have a thick neck, all those things are indicators that you may have sleep apnea, but some slim people also do. So if you're tired during the day, you feel sleepy during the day, and it's not like you're not having restful sleep, those all may be signs of sleep apnea. And sleep apnea, if it's not well treated, can predispose you to hypertension, heart failure, kidney disease, atrial fibrillation, and all the bad stuff. So if you have conditions like that, it's good to be checked out. They'll do a sleep study and put you on treatment in the form of, say, CPAP or BiPAP or other devices that will keep your airways open when you sleep so you can breathe well, take in air and sleep nicely, So we have to treat high cholesterol also because we mentioned what harmful effects high cholesterol can do to blood flow to your vital organs. So when we talk about prevention of heart disease, we're talking about lifestyle changes. We're talking about treatment of disease, treatment of hypertension, treatment of diabetes, atrial fibrillation, to prevent further heart disease or further complications. Yeah, thank you so much for having me. I'm sure I've bored you stiff with a lot of this stuff, but I think it's very important. If you have any questions, the floor will be open now. By the way, Mr. Day, if you want to come in now.
Sure. Yo, Doug, Akpe Garden now. I would like to thank you so much for enabling us to partake in your crash medical course this evening. It has been very exciting. And I'd like to recognize a pretty nurse. She's joining us all the way from Ghana. Either she's in Ghana or she's in UK. I don't know who else is in that part of the world, but it is 3-something AM in her time zone, and for her to be staying up and partaking and joining us, it's very remarkable. And everybody else that is joining us in that time zone, would like to thank you so much for partaking in this seminar. Doc, I would like to thank you so much. Most of you may have realized that most of you may have been muted but we wanted to hear Doc Mikboba Dog. So we muted most of you so now you can unmute yourself. I'm not gonna have any question at that, then you can ask Doc. Doc, you took us through a very elaborate name. You started talking about, you mentioned alcohol. I kept towards the end, you almost got me confused. But there is nothing good about it, yet there is a benefit to it. But conquer the car, and you don't wait until you batch drink in the weekend. So I got a little confused there, because you have a plumber. If you work during the week, you can wait until the weekend and become a weekend hero. I was really looking forward to that, Gaka. And one other thing that I learned, but you talked about cold feet. I thought, but then another strong the yeah, and look at your name. Your wife got a cold feet. She became a little hesitant and don't want to marry you anymore. Gaka, here you were talking about it was a peripheral arterial disease. Young Baba cold feet. Well, I'm at a happy nama. Yeah. So you talked about, but I was just wondering the way you talk about cholesterol. You did share a lot of information on cholesterol. Gaka, you were talking about red meat. Are you saying when we got light soup, it is not good for us, so we should stop the goat light soup and whatever. We should only do a chicken, and even the chicken akraha, we should take the skin off, and then that is what is good for us. And yava food them lo there was quite a lot of information that you've given us tonight. But me got no milk, pasteurized any dairy product, and ya food them low. Anyway, nyana no man yama kwe man nyama say nyama. But most of you has more interesting questions, and if you want to ask a question, Mother Kukuba, just we have about 40-something of us here online. And if you have a question that you want to ask Adi, Michael, just raise your hand. Raise your hand, then we can identify you, and then you can ask your question. I'll go around and begin to unmute everyone so that you can ask your question. Mr. President, Michael, okay, I have Geraldine. That Geraldine, Michael, Geraldine, please go ahead with your question.
Okay, Dr. Motosi, thank you very much for your presentation.
Oh, you're most welcome.
I have a question. So you talked about irregular palpitation, and in relation to your KGB or what?
EKG.
Your heart thing, what is it called?
EKG or
EKG, yeah, sorry. So I'm a scientist, so I don't know this. And can you have irregular palpitation and have good EKG results?
Yes, and number one, it's not all. So not all that is irregular is atrial fibrillation or atrial flutter.
Okay.
They have normal beats with premature beats, and that will come out as irregular. Usually, atrial fibrillation may not be sustained. It may be what we call paroxysmal. So you may have it sometimes and not have it other times. So sometimes patients may come in and say, oh, I had an episode of fast heartbeat. It was so irregular. But when they come to you, they may be in normal beat at that time. So you do ECG and it will come out normal, you know? Sometimes what we do is we put on a monitor that you take home with you.
Yes.
That we can catch it when it happens again, like a monitor you wear for a day or two, or sometimes a whole month, or event monitor, just for us to see what is causing your fast heartbeat or your irregular palpitations. Yes, I hope I answered your question.
So
now,
if you get a heart monitor and they don't see anything for a few days, and then you still experience that little palpitation, and your cardiologist says, oh, this will go away, just stop drinking caffeine, is that a good thing?
Well, again, say, for example, caffeine may just be causing maybe your normal heart rhythm going fast, or what we call sinus tachycardia. You may see that on EKG or not if you're not in sinus tachycardia at the time of doing EKG. Remember, EKG is just a snapshot of what's going on at the time that you're being tested. So if you go home and it happens and nobody's monitoring you, we will not know what's going on. The other forms of fast heartbeat, that's when sometimes we make you go home with a monitor to see if it happens, we can catch what exactly is causing your palpitation, you know? So if a doctor says your caffeine may be triggering fast heartbeat, that's true. And sometimes when patients cut back on their caffeine, then the fast heartbeats will reduce, because caffeine can stimulate your heart and cause sinus tachycardia, just normal rhythm going fast, as though you were exercising or something like that, you know?
Okay,
Now,
thank you. Thank you.
Thank you very much. Let me just touch briefly on
we have a question from Senna. Do you want to take Senna's question, then maybe you can tie into what you wanted to say, Doug?
Okay, yeah, that's fine. Yeah, Senna, please.
Okay. Yeah, Senna, please go ahead with your question.
Can I speak in English? Which one?
Okay,
I think we did the whole thing. Yeah. I want to talk about the coconut oil, or what you call NOMI.
Mm-hmm.
You know, in the past, when they used to do the oil, I mean, it doesn't become solid at room temperature. But now that they are using machines to do it, you get to see them to be in a solid form. Because my mother was oil in Anloga in those days. Now, I know some time back they told us to do away with coconut oil and move to soybean and the rest. But we got to know that they were just trying to impose those foreign oils on us. Now, research has come back to show that coconut oil, like our parents did in the days, were really good because they wouldn't become solid at room temperature because they are medium chain fatty acids. Now, you mentioned that they are not good for us, but here's the case. They've told us, the researchers have told us, we should go back to pick it from where we left. Now, what are you saying about that? Because I have been using coconut when I'm back in Ghana, that's what I use. And I have my lecturers here who are in food and nutrition who come to buy oil from my mother. So if you could just elaborate on that.
Yeah, that's a very good question, Afu. Yeah, you know, the coconut oil that has more medium chain fatty acids are good, you know, but it takes special processing to get it that way, you know. The regular one, which is solid, has more saturated fats, which are not good for your health. Like we said, they increase your bad cholesterol, your triglycerides, decrease your good cholesterol. But with special processing, if you're able to get these medium chain fatty acids, those are good. One thing I did not mention also about fat is good fat is omega-3 fatty acids. Those are also very healthy fats for cardiovascular health. And in actuality, they are polyunsaturated fatty acids. Those are also very good. You find that in salmon and mackerel and other fishes like that. So yeah, so the answer to your question is coconut oil that is solid has more unsaturated fat, 80 to 90%, more saturated fat, 80 to 90%. That's not healthy. But the one that has the medium chain fatty acid, which takes special processing, maybe healthier than that. I hope I answered your question on that one. Now, before I take the next question, I want to answer Food Day's questions real quick. So cold feet doesn't necessarily mean that you have peripheral arterial disease. Some people are just like that. I have cold hands. Some people have cold feet, but it doesn't mean they don't have good blood flow. Number two, like I said about alcohol, number one, no amount of alcohol is safe. If you want to drink alcohol, we encourage moderation, and we went over that. But you don't want to binge drink. You don't want to at one sitting drink a whole lot of alcohol because it's harmful. And also with the red meat, right? The goat and stuff. See, the red meat has small amount of trans fats. In this country, trans fats have been outlawed by policy because, you see, it's cheap for restaurants to use that to fry food, to use that to make cookies and fry their food and all that. So, and it's so harmful. A lot of states, have laws against having trans fats in your food. But in a developing world, there's no such policy or regulation against them. So people can still use it at home to cook. They use it in the restaurants to cook. So we have to be very careful about that. So trans fats, we say avoid. Now for saturated fats, we say replace it as much as you can. In fact, according to the American Dietary Guidelines, they want you to stay below 10% of your caloric intake should be less than 10% should be saturated fats, So yeah, goat has some trans fat, but it also has, the meat, the fat part of it has bad fats, the solid fat part of it. So you can make it lean by taking off all those solid fats, and just eat the lean part of it. But we say do not eat it too frequently, do not eat red meat too frequently. Processed meat is not good, like sausages and stuff. Yeah, it increase your cancer risk and all that. So yeah, goat meat, but moderate it, take out the fatty parts, and eat only the lean part. So that's the answer to your question. Milk also. Milk, also everything is in moderation,
Okay.
Milk has saturated fats and all that. Yes, just moderate the use of it.
Okay. Yo kepiano ane almond milk plato mo numama kaya nyo di.
Almond milk is a plant-based milk, so it's healthy.
It's healthy. Okay, Akbar.
Yeah.
Okay, Sonny, Sonny, you are on an iPhone, please. Now I have a question, please. You have the floor.
Maracuyo nkonye sama. Okay, Dr. Akbar's presentation. Your question is two parts. One, you talked about cold feet. There are some times that there is one that they refer to as neuropathy, where the feet feel rather warm or heated. Does that have any correlation with cardiovascular disease? And then the second one is frequent muscle pull, what we call muscle pull. You'll be walking and sometimes you just feel this muscle pull, or you're lying down, you have muscle pull. Does that have any correlation with cardiovascular disease also?
Okay, thank you for your question. So again, about cold feet, it looks like this is a very
cold feet, that would have blown.
About hot feet, hot feet.
Neuropathy.
Okay, yeah. So neuropathy is when you have problem with the nerves, that supply the skin and the muscles and everything. So when you have problem with the nerves, it may cause exaggerated nerve feelings like you may have warmth, like hot pepper on your skin. It may be like pins and needles pricking you. Those are all abnormal nerve sensations that you can have because of conditions. Now, peripheral neuropathy is usually due to small nerve disease. So it can be because, one, you have poor blood flow to the nerves, because the nerves also have blood supply. So when there is poor blood flow to the nerves, it can cause nerve disease and you have neuropathy. So if you have, say, peripheral arterial disease, it may present as neuropathy. Diabetes will present as neuropathy, especially if it's not well controlled, because diabetes causes small vessel disease. And these small vessels supply blood to the nerves. And then when those blood vessels are compromised, then the nerves will also be diseased and it will give you neuropathy. So neuropathy can be caused by so many more things outside of cardiovascular, but cardiovascular disease can also cause neuropathy.
Okay.
If that answers your question. Now, muscle puller. Well, I don't know. Now, sometimes you have athletes who are running and then they have a pull, right? That may be just from muscle fatigue because of waste products that are accumulating in the muscle because of exercise. But some people may mistake that or may mischaracterize, say, claudication as muscle pull, maybe. So when you're walking and you have pain in your calves or in your thigh, and when you stop, it goes away, that's claudication, but somebody may call it muscle pull, so you never know. So it will call for you to come and get us to question you some more and do some testing to see if you have peripheral arterial disease.
Okay.
You talked about exercise, aerobic exercise. Yeah, you talked about 150 minutes a week, although vigorous exercise for 75. Ka marakuma bialo abama tonhadi iha menya exercise nya. Yeah, I think glomba divide 150 into the week. Ka glomba at least Ejaba na wodoni, you know, about 30 minutes a day. Allo 50 minutes a day. 5 minutes a day. Ka dola me mari allo.
Oh, yeah, exercise.
Exercise.
All exercise is better exercise. We're talking about cumulative. When you add it all up for the whole week, that's what we're saying. But it will not be practical for most of us. But any exercise is better than no exercise. Just do some exercise. It's just a guidance. It's from American Heart Association based on Amopa research or if you're able to do cumulatively 150 minutes over the course of the week, you stand to benefit so much in terms of raising your good cholesterol, decreasing your bad cholesterol, and stuff like that. But like I said, you know, just do some kind of exercise. Any exercise is better than no exercise.
Papa, I can see Jordan got very interested in my question. So Jordan, I see you have your hand up. Please go. Please, you have the floor.
Yeah, if you have a brother who is a cardiologist, you make good use of him. So
absolutely, I agree with you.
Yeah.
So doctor, you talked about type 2 diabetes, and some of those things are signs of heart cardiovascular diseases. So what about people who were born diabetic? How will they differentiate situations like that when they are having any cardiovascular symptoms?
So again, diabetes is a disease entity on its own. But what I was saying was diabetes can lead to heart disease, especially when it's uncontrolled. So anybody who is born with diabetes, we call it, you have type 1 diabetes, which may be insulin dependent. Do you know, but this American Supreme Court judge, Sonia Sotomayor, has diabetes from childhood? But I'm sure it's well controlled. She's lived, I mean, pretty decent life, and she's still going strong. If diabetes is well controlled, you can prevent most of the complications that come with it, you know? So a complication of diabetes can be heart disease. It can be heart attack. It can be heart failure. It can be other stuff. But it does not mean that diabetes is heart disease or heart failure. We say diabetes predisposes you to heart disease. I don't know if I answered your question.
Actually, I wanted to know because I have a friend who was born diabetic, and then like I can imagine how she would be able to know that I have a sign. Like if I have type 2 diabetes now, I'm going to be worried and try to control it. But somebody who is already born with this insulin dependent, I'm just trying to find out what other way, apart from some of those signs, could help them.
Well, so most of the time, let's say for type 2 diabetics, right? Diabetics, you may not even know you have diabetes until a complication sets in. Mm-hmm. So how does it present? Typically, diabetes may present as polyuria, which is peeing so much and drinking a lot. So you're drinking a lot, you're peeing a lot, weight loss, you know, those may be indicators of diabetes. And then we'll check your blood sugar, and then we realize, oh, you have diabetes. Sometimes people come in an emergency situation. They come, they are comatose, you know, and then you check and they have what we call diabetic ketoacidosis. That's the first time they've ever been diagnosed as diabetic. So you may not even know that you have diabetes, you know, but if you do regular routine follow-up and they check you, they might find it out and start treatment. Or you may not know until you come up with a complication like diabetic ketoacidosis, which if you're not lucky, you're going to die because it's a very high risk condition. For type 1 diabetics from childhood, they may find out as children, and they may be on treatment. But if your question is, what are the signs and symptoms that will make you suspect that you probably have diabetes, the main ones are weight loss, peeing a lot, drinking a lot, so polyuria, polydipsia, weight loss. Those are the cardinal symptoms. Or you may have problem with your eyesight. So those are complications. So if you have diabetes for a long time, and then you may develop complications with your eyesight, neuropathy. So you may have maybe poor sensation in your extremities, or even burning sensation, pins and needles. Those all may be signs of complications from diabetes. Those are things you can look out for if you have them. Diabetes can lead to kidney disease, can lead to heart attacks. Sometimes people come with heart attack before we diagnose them with diabetes, you know? So those would be the complications. It may be a reason why somebody presents. But the cardinal symptoms will be polyuria, that means peeing a lot, drinking a lot, weight loss.
Okay.
Thank you.
Doug, I have a question. I know Dr. Doris Jamashi have her hand up, but I have a quick question for you from one of our participants. Says, what is the best way to control cholesterol and thyroid?
And thyroid?
Yes.
Okay, cholesterol first. So best way to control cholesterol is number one, diet, right? Diet is good. It's a good way to control cholesterol. Lifestyle changes, exercise, like we said, exercise will increase your good cholesterol, decrease your bad cholesterol. Weight loss will have some beneficial effect on your cholesterol. And then diet, avoiding the trans fats, the bad fats, the saturated fats, you know, cutting out the red meat and stuff. Those will affect your cholesterol positively. And then, so we have thresholds at which we treat cholesterol. So for example, if you come, we do a cholesterol check. As cardiologists, what we do is we calculate your 10-year risk for cardiovascular disease. If your 10-year risk is high, we put you on cholesterol medicine. But as an adjunct to that cholesterol medicine is lifestyle changes. So you do both together, lifestyle, and sometimes we have to treat it with medicines. And these medicines are the statins, commonly the statins, the evil statins that everybody doesn't like. They come and say, I have leg pain. Is the statins that's causing it? So like Lipitor, Crestor, simvastatin. Yeah, those are the main drugs that control cholesterol. They have good benefit for cardiovascular health. So statins, you know, sometimes you may use ezetimibe or Zetia. Triglycerides can be controlled with fenofibrates, with niacin, with fish oil. Fish oil is very effective in reducing triglycerides, you know. So fish oil can also do that. You can buy it over the counter, or we have prescription fish oil called Movesa and other prescription fish oil. So medical treatment is number one, and lifestyle changes. In some people, your cholesterol may not be high enough to qualify you for medical treatment. We'll just recommend lifestyle. Quit smoking. Smoking, if you quit that, that can affect your cholesterol positively. Exercise, lose weight, stuff like that.
Okay. Dr. Doris Damashi, please, you have the floor.
Thank you. I just wanted to find out what would be the relationship with having high vitamin B and heart disease. What would be that relationship?
Well, there are so many vitamin Bs, right? There's so many vitamin Bs, you know. You have B12, you have all those kinds of things.
B12.
Pardon?
It would be
B12.
B12,
yeah.
Yeah. So, you know, B12 deficiency, let's start with deficiency. B12 deficiency can lead to neurologic effects, you know, neuropathy, other neurologic effects, and it may also affect the heart. Vitamin beriberi, which causes actually heart failure, where people get swollen with water, fluid and stuff. It's actually due to a vitamin B substance deficiency. So those can cause heart disease. And the way to prevent that would be to have adequate amounts of those vitamins. But when you have excess vitamins also, some of them can lead to deleterious effects. We do have some well-defined ones, like when you have excess vitamin A and stuff like that. Some not so well-defined, but usually it's always good to keep within the normal limits or the normal ranges for the vitamins, all of them.
Okay. Yo, Doc, Mr. President,
somebody asked a question about thyroid, which I did not.
Oh, yes. That was a combo question about cholesterol and thyroid also.
So if I remember correctly, can the person repeat the question about the thyroid again?
It said, what is the best way to control thyroid? It was
What's the best way to control thyroid? Yeah, you know, if you have, say, low thyroid, then it has to be replaced. It has to be replaced with levothyroxine. So you get it replaced, and every now and then we check it to make sure that the thyroid is back to normal levels. When the thyroid is overactive, excess thyroid levels, then you have to find a way to decrease it. And there are three main ways to do that. Will be through medication, you know, that would decrease the thyroid, through surgery by removing the thyroid gland or part of it, or radiation therapy, where they apply radioactive iodine to the thyroid to kill off the thyroid cells to decrease the thyroid levels.
Okay.
So it's medical treatment, yes.
Okay. For Senna, I think you have a question. You had your hand up.
It's a question and a suggestion about the same time. He mentioned also about those who drink, that they should drink in moderation. And then he was trying to use glasses without measure. For example,
about the color.
When we take the Germans, I hope if they have tall glasses, that's to them. Do you get it? So if we are not specific about the measure, we run into difficulty. So that's what I want to add.
Okay, very well.
Yeah.
Akbar.
You.
Your point is well taken.
I mean, our beer bottles in Ghana they have glasses. We can take about 4 of those bottles. They have
okay. Let me make myself a little bit clear if I wasn't successful at making that.
Yeah.
I was saying, buddy, when we talk about a unit or a drink, it varies based on the type of alcohol we're talking about. If it is wine, a glass of wine is considered one drink. If it is hard liquor, a shot Concord Kasui, Tomari, is considered one drink. If it is beer, we're talking 300 cc, that small kind of beer. So Abagana mini beer will be considered one drink. The big beer bottle will be about 2 drinks. So that's a rough measure, just for you to understand what we mean when we say no more than 1 drink a day or no more than 2 drinks a day.
Yeah, that's a good explanation, because I don't drink. I'm a teetotaler, but then I wanted to get to the people because I've been with the Germans. I know when you just say this, they'll go and look for the largest glass and make it just 1 shot.
Okay.
Oh,
Yo, all right, yo, akpana afosana Marco azado domita Marco. One last question. Anemia dashi a dog because a exercise will try as a meta mia dashing when we exercise we are there.
I joined D because I have
okay.
An interview on TV for.
Oh, okay. Yo, Marco, Marco, last question. I can reserve a last question and me have a president.
Oh, matter if it's okay, yeah.
Okay. Yo, for David, Marco, nanyara la shua, Marco ka abiana miakoko end up and nemia nana dog naga nami have closing remarks there mia ako egbabo one on her nemia work babo one on. Mr. President, Marco, the floor is yours, sir.
Okay. Yes,
I'm on call, sir.
Can you hear me? Am I on mute? Okay.
No, you're not on mute. Okay.
Okay. For all the information he has given to us tonight, we've scheduled 1 hour for this presentation, but we've gone way over it. Thank you for all the patience. Since the story is good, we all forgot that it is time or the 1 hour have passed. So I just want to take this opportunity to thank him for his time, for the thorough research he has done. And also those who have been on the call or on the seminar tonight. This is something we plan to be doing on a quarterly basis. The next quarter, which is the 2nd quarter of this year, it might be a different topic and all the information will be passed around. And all these things being organized by ADANA, that is Anloga Development Association, North America. We are a group of Anglo citizens or AWA people who are residents in North America, and we are open to all the AWAs within from Ghana. If you champion any idea, anything that AWAs do, you wanted to contribute towards the development of our homeland, AWA land, or Anglo area, you are more than welcome to join. We have a monthly meeting. We normally meet on the 4th Wednesday of each month. So you are more than welcome to join us. And if you have any other information, feel free to dial the number on that appear on the flyer. So I thank you all for coming tonight. However, this is not the end of the tonight's program. So I'll yield back to Chairman Steve to conclude. Thank you.
Yo, Mr. President, Marco Agbogbulamba, okay, anyway, Mr. President, yo, Marco, now we don't have any question for Doga.
Steve.
Huh?
Steve.
Yeah, Marco, yeah.
Oh, and Charles, yeah.
Oh, Charles, sorry, Mr. Charles, no way, yeah, no way.
Merakude, miatawana, doko information. Ne amerebe have a personal question here at you are be a new year. Kimine miakota the platform ne doc aloa. Na me that the question really ameresi valley meton be a question or that's a personal question. I mean that be a if is willing to take those type of questions. I be a call information or add that number, low email or something like that. Hey, I'm at that you have here. Yeah, call us in your penemy.
Yo, for Charles, can my consultation in my local job and have consultation fee. Ni appear a majiji fun ita matwa ayi yakubu ayi akwene ko aka na to have consultation ma Mr. President Marco Sagbadi Marco for chance you request him but me call a doc for information now you have your private where you have a serious private a tit-a-tit now you have a dog it Yo, Marco, that question I come again, dog, Marco, if you can then. Okay, yeah, Doc, Marco, if you can give us your closing remarks, please.
Oh, I just want to say, Madak Banamikatan, for giving me this opportunity to come and talk to you about what is very dear to my heart. This is what I do for a living. And Baroboa, Milafia, me, we are happy to have this opportunity to help our own people, you know. The Ajoji number me invite them. Hey, Mioha, you attended this presentation to listen to what I had to say. So for me, it's a great honor that you open your living rooms to listen to me. Akbanami, if in the future you want to invite me again for another talk, I'm happy.
Yeah.
To avail myself.
We need you. We need you. We need you for more talks.
We need another one.
Yeah, I'm happy to avail myself,
yes.
because
we need you for more talks.
I want my people to benefit from my expertise as well.
Next quarter, we need one next quarter.
Okay, yeah, that's fine. Yeah, so
Sister Jordan, you have to come and see me first. So before we bring dog again, I take consultation fee. I
will see you in camera.
Okay. All right. Yo, Doc, Marco, let me also thank you so much for taking time. Marco, bye. Okay.
I get video to them.
Me were recording it. I president, but president were recording. Yeah, okay. We are but we intend to broadcast it again on Facebook, back YouTube. He does have the recording. It's recording on. It's being recorded, so we'll be able to. Hello, Mr. President. Do you want to answer that question? A question about how do you get a copy of the recording?
You've answered it perfectly right. We have a recording that we posted on the Facebook. It's supposed to be streaming live on Facebook, but because of some technical challenges, it's not. But the recorded version will be posted there very soon.
Okay.
Yo, Doc, Akbar again, and for the 40-something people that tune in from all, various time zones, we would like to thank you all for joining again. It's been a pleasure to have asked me to moderate this. I am most delighted to have served this purpose. I will now yield the floor to the president to take us home. Mr. President, Marco Akbar.
So one more time, Akbana, Chairman Steve, and Dr. Mototi for leading tonight's presentation. I can see from the excitement, even though it is late in the night, especially at the East Coast, but they are still eager to ask more questions. However, the other talk about Vivima Vonalakonu, I feel calling for. So let's end it here, and then we'll meet again within the next quarter for either the same topic or a different topic. So on this note, I thank you all for coming. I've enjoyed your presence, your participation. Keep the word going about ADANA. We don't have to take care of our brothers, only our brothers and sisters back at home. We need to take care of ourselves as well. And that's the reason why we are here tonight, to educate ourselves, to keep ourselves healthy. On this note, the meeting is adjourned, and thank you all. But if anybody officially adjourned, but if anybody wanted to social network or stop the recording by now, you can pause.